Hello, and welcome to the CAP Today webinar for Tuesday, June 14th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host, and I'll moderate a Q&A session after our formal presentation. Today's webinar is entitled New Perspectives on the Full Spectrum of HER2 Expression in Breast Cancer. This is a very important webinar and very current webinar. It's sponsored by Daiichi Sankyo and AstraZeneca. We want to acknowledge them and thank them for their help in enabling us to bring you this important session. Our single speaker, and I'll say more about him in due course, is Dr. Gary Tozbikian of the Department of Pathology at Ohio State University in Columbus, Ohio. But before we begin, I'd just like to go through some simple housekeeping steps that I think can enhance your enjoyment of today's event. We recommend that you refresh your browser. I also want to call your attention to the lower right-hand corner of your screen. We have live help available throughout today's presentation. You can dial a toll-free number of 858-345-5916 with any technical problem, whether with the website or the audio, and someone will be right there to help you. You will see below the slide a question and answer box. Q&A is the label there. You may also type in comments or questions regarding your need for technical help with today's webinar in that box, and we'll pay attention to that immediately. Again, live folks are here to help. Of course, that Q&A box is primarily intended for your comments and questions. You can type those in at any time during today's webinar, and as I said, we'll get to those after the formal presentation in our question and answer session. You will see the full slides and audio of today's webinar in approximately a week or 10 days, and you'll see that at captodayonline.com. I can assure you you'll enjoy a chance to review this very timely and rich presentation. You're going to see some follow-up email from us and perhaps from our sponsors, so I wanted to alert you to that fact. And my final little tip on the housekeeping is to remind you that CAP Today does not endorse any product or service that may be mentioned in this webinar today. Of course, any comments that I make are purely personal and not to be taken as the policy of the CAP Today or the College of American Pathologists. And now, let's begin our program. And I want to tell you a little bit about our speaker. Dr. Gary Tozbikian went to medical school at The Ohio State University in Columbus, where he is currently Associate Professor and Director of the Division of Breast Pathology in the Department of Pathology at the Wexner Medical Center at The Ohio State University. He did his AP and CP pathology residency at the Hospital of the University of Pennsylvania, and then did a breast fellowship at Memorial Sloan Kettering. So we're very delighted to have him. He's a well-known speaker, and we've always enjoyed working with Dr. Tozbikian, and I'll ask him to begin his presentation now. Dr. Tozbikian.
Hello. Welcome, everyone. Thank you so much for attending this webinar presentation. Today we'll be discussing HER2, a topic of vital and recent renewed interest in breast cancer. Now, namely, we will be focusing on exploring issues across the full spectrum of HER2 expression in breast cancer. And it's interesting. It's been over 20 years, actually 1998, since the FDA approved the first anti-HER2 targeted therapies for use in the treatment of breast cancer. And since that time, this topic has remained highly significant and in some ways controversial. We've seen multiple revisions to the HER2 guidelines, with each refinement a response to new data and a better understanding of HER2 biology. Likewise, we've observed changes to the HER2 treatment landscape, which continues to evolve. And so HER2 has remained a very vital and relevant topic of discussion, which I'm happy to present some new perspectives with you today. Very briefly, these are my disclosures. I also wanted to mention that during this presentation, we will pause a few times to conduct an audience poll, so please be ready. I would love to have your participation. Here is an outline of our learning objectives today. We will briefly review HER2 biology and its role as a predictive biomarker in breast cancer. Next, we'll cover HER2 testing and scoring, and also how that has evolved over the years. And we'll particularly focus on tumors with low levels of HER2 expression. We will also examine some of the technical and diagnostic challenges to HER2 interpretation, particularly at the lower spectrum of HER2 expression. And finally, we will close with 3 case examples that will serve to highlight how many of these issues may be encountered in clinical practice. So unfortunately, as you all know, breast cancer is a major disease that affects many people. Based on SEER reporting, the estimated number of new cases of invasive breast cancer was over 281,000 patients in the United States last year, and it is the second leading cause of cancer death among women. Now, as per guidelines, all primary invasive breast cancers are assessed with your standard biomarker, breast biomarkers, estrogen and progesterone receptors, and HER2. Also, ASCO recommends that biomarker status be reassessed in all recurrent and metastatic lesions where possible at the time of progression, as this directly impacts therapeutic decision-making. Also of note, ERPR and HER2 provide an approximate assessment of a breast cancer's molecular subtype, which can have prognostic implications. But in the end of the day, it is this sort of combination of various clinical and pathologic information, the staging assessment, as well as biomarker status, which largely guides and informs treatment selection. As you're all well aware, HER2 is part of the ERB family of cell surface receptors. These are powerful regulators of cell growth, survival, and differentiation. They activate a host, multiple signaling pathways, PI3, AKT, etc., that promote proliferation, angiogenesis, anti-apoptosis, etc. HER2 is oncogenic largely due to gene amplification, which results in downstream receptor overexpression on the cell surface. Consequently, HER2-positive tumors are associated with more aggressive behavior, poor prognosis. HER2 has been linked to several different cancers in addition to breast cancer, including cancers of the GI tract and GYN tract and others, where it is a biomarker of major prognostic and predictive value. So this slide summarizes a timeline of some of the key events in the history of HER2 therapy. The HER2 gene was first identified in 1984. In 1998, the FDA approved the first anti-HER2 directed therapies for use in breast cancer, and we have seen the clinical landscape continue to evolve with the addition of different classes of therapies. In 2007, ASCO-CAP issued the first guidelines for HER2 interpretation, which were revised in 2013 and again updated in 2018. But really the take-home message I want to share here is that HER2, the way we evaluate it, also in the therapeutic strategies available for targeting it, really continues to evolve. In this slide, we see an outline of how the ASCO-CAP HER2 guidelines have also evolved over the last 15 years, and this has occurred, again, in response to new published clinical data, also feedback from pathologists and the wider clinical community. Now, there isn't, enough time to cover every single change, but I will highlight some of the few key updates. Initially, based on the FDA label for IHC, HER2 positivity was defined as greater than 10% strong membranous reactivity. In 2007, the ASCO-CAP guidelines, based on concerns about false positive rates, the cut points to consider someone HER2 positive for IHC was raised to greater than 30%, and the FISH cutoffs were increased as well. In 2013, the pendulum sort of swung in the reverse direction. There was concern now for false negatives. The HER2 cut point was returned to greater than 10%. The ISH categories were modified again. For example, an ISH equivocal category was created at that time. And finally, in 2018, in order to address some of the problems and issues with HER2 equivocal status, and also based on additional clinical data, the cut points, particularly for HER2-ish, were revised yet again. But the take-home point I want to make here is that all of these various iterations of the ASCO-CAP HER2 guidelines continue to attempt to address the complex nature of HER2 biology and also improve our testing quality, with a focus to this point to improve our ability to identify those subsets of patients who might most benefit from available anti-HER2 targeted therapy. And, in this respect, the ASCO-CAP guidelines have been very successful. This data I'm showing here is from a recent publication by Pfizer et al. From Germany. This was published in Modern Pathology. They compared the discordance rates between central and local HER2 testing for a total of over 1,500 patients across 5 different clinical trials that took place over a period of 12 years. These were the GEBAR trials. These were neoadjuvant, prospective, multi-center randomized studies in patients with primary invasive breast cancer. And what you see here plotted on the y-axis is the discordance rate for each trial. And each column here represents the 5 different clinical trials. So the column on the left, GEBAR Trio, which was the oldest trial in which patients were enrolled between 2001 and 2005. So this is prior to the first ASCO-CAP guidelines. You can see in that trial the discordance rate was very high, over 50%. Compare that with the more recent trials, GEBAR Sixto and Septo, which began enrollment in 2011 and 13 respectively, and you can see agreement between local and central HER2 testing increase significantly. And so it's data like this and others which really point to the success of the ASCO-CAP guidelines and adherence to those guidelines in improving the standardization, the quality, and consistency of HER2 testing that is done in clinical practice. So as I mentioned before, the HER2 consensus guidelines have evolved based on available data and have largely focused heretofore on identifying patients who are eligible or should be eligible for currently available anti-HER2 targeted therapy. And as a result of this, the current guidelines adopts very much a dichotomous system to HER2 classification. And in this slide, I'm showing you the most recent ASCO-CAP guideline algorithm for HER2 classification, here assuming a testing protocol that many labs follow that is leading with IHC. So following this algorithm, if your IHC result is 0 or 1+, the patient is considered HER2 negative and no further testing is required. Of course, assuming your results make sense, the controls look good, etc. In contrast, if your result is a 3+, the patient is considered HER2 positive, and likewise, for the most part, no additional testing is needed. If your IHC result is a equivocal 2+, then reflex testing by ISH is done to arbitrate and eventually classify the patient as either negative or positive. And this binary approach to classification is very much driven by the current therapeutic landscape and treatment strategies that are currently available. The issue with this approach is that, and really the interesting point is that in reality, HER2 biology is not so simple and not so dichotomous. In breast cancer, in clinical practice, what you observe is that HER2 IHC expression exists as a continuous spectrum. Among the 85% of breast cancers that we currently classify as HER2 negative, a large proportion, approximately 60%, will demonstrate some low level of HER2 expression as defined as having a HER2 IHC score of 1 or 2+ without amplification. And this 60% frequency is derived from the work of Shattini et al. This was published in Nature Partner Journals Breast Cancer. This was a European study that evaluated 13 independent data sets involving close to 3,700 patients. And these 60% of patients with low levels of HER2 expression is a group of increasing clinical research interest. And so recognition of these tumors necessitates really a better understanding of all aspects of this emerging area of clinical focus. So let's talk about breast cancers now with low levels of HER2 expression. Currently, no formal definition of these tumors exists. However, most published studies that have looked at tumors with IHC expression of score 1 or 2 plus without HER2-ish amplification have demonstrated that these cancers may have different clinical and pathologic features as compared to HER2-negative tumors with an IHC score of 0. So, for example, in a series by Schettini, breast cancers with low levels of HER2 expression were significantly more often hormone receptor positive, and this is demonstrated by the pie charts here on the right, showing 88% hormone receptor positivity versus 70% in those that are HER2 score 0. In that series, tumors with low levels of HER2 expression also showed significantly larger PT size, more frequent nodal involvement, and PAM50 analysis showed differential gene expression with more frequent luminal expression profiles. Now, in Schettini's study, there was no difference in grade. However, some other studies indicate that these tumors may show comparatively lower histologic grade compared to your HER2 IHC score 0 tumors. So, this subset of tumors may have some distinguishing biologic features, but it is important to remember, as a category, breast cancers with low levels of HER2 expression constitute really a large number of tumors that demonstrate a wide degree of clinical and biologic heterogeneity. And speaking of heterogeneity, sort of further complicating the issue, as we all know, intratumoral heterogeneity for HER2 expression is not uncommon. It certainly adds to the interpretive challenge of HER2 evaluation and is a frequent cause of your HER2 equivocal results. A number of studies of HER2 non-amplified tumors with genomic heterogeneity have shown that associations with larger T size, histologic grade, lymph node metastasis, while in HER2 positive tumors there is published data that suggests intratumoral heterogeneity for HER2 is associated with negative prognosis, lower PCR rates to neoadjuvant chemotherapy, etc. However, the prognostic significance of low levels of HER2 expression is less well understood at this point. There was a recent European study by Agustinetto that looked at the prognostic impact of low levels of HER2 expression. That was looking at a data set from the TCGA. In their series of 804 cases, of which half, or about 410, had low levels of HER2 expression, they observed no difference in overall survival or progression-free interval, though with relatively short follow-up of under 28 months. But the take-home point I want to make is that intratumoral heterogeneity, it's there. It certainly makes HER2 interpretation more challenging. It may impact prognosis, but the prognostic implication of low levels of HER2 expression, as well as intratumoral heterogeneity for HER2 expression in these tumors, deserves further study. So at this point, we're going to transition here and now focus our talk on HER2 testing. And if we're going to think about identifying cancers with low levels of HER2 expression, we will need reproducible, high-quality assays to identify them. And in the near term, we must really optimize our currently available diagnostic assays and practices. And frankly, here, we may face a challenge. This is a table I'm showing you from an interesting study from Yale that was recently published, got a fair amount of attention, that was looking at inter-observer agreement in the CAP HER2 TMA proficiency surveys. And what they did is they looked at 2 years of survey data involving a total of 80 cores scored by over 1,400 labs. And the results you can see visualized in this picture here. You can see for each TMA core, which is represented by a pie chart, an individual breakdown of the score frequencies, 0 to 3 plus. They're color-coded. And so you can see across the top 4 rows, those are cores in which the vast majority of the participating reviewers, pathologists, scored these as a 0, so they appear dark blue. On the bottom rows, you can see cases in which the consensus score was a 3 plus with very high agreement, so these are yellow circles. And so overall, for the determination of HER2 positive versus non-positive status, the concordance rate was very high, over 90%. However, if you want to look at performance on distinguishing HER2 IHC score 0 from non-zero or 1 plus, that concordance rate was lower. You can see here in the middle rows highlighted of the cores that are highlighted inside the black boxes, there was a subset of about 15 of the 56 negative cases, or about a quarter of the consensus HER2 negative cores, in which agreement was low, and the concordance rate was less than 70%. So looking at this data, sort of on the surface of it, the data seems to suggest that pathologists may find it challenging to discern score 0 from 1+ expression, at least, maybe for a subset of cases. I do think the study, when you look at it, you have to read between the lines a little bit. And I think also, based on study design, at least to me, seeing results of low agreement for 0 versus 1+ is not surprising whatsoever. And that's probably due to a couple factors in the study design. First, using CAP proficiency surveys is perhaps not the best choice of specimen for this type of study, to be quite frank. Personally, having taken some of these CAP HER2 proficiency surveys for quite a long time, the survey, as it's currently formulated, is not really designed to parse out cases with low HER2 expression. That survey is really designed to assess whether labs are competent in discerning HER2 positive from negative results. They don't, usually feature tumors with a full representative spectrum of HER2 expression. You see mostly the extremes represented. Second, and possibly a bigger factor, has to do with the way in which most users may have approached scoring these TMAs. The pathologists obviously were blinded to the intent of the study. I would imagine that perhaps not much bandwidth was or is paid by participating pathologists to scrutinize 0 versus 1+ on these CAP surveys. Why? Perhaps because in CAP proficiency surveys for a negative tumor, it doesn't really matter if you score a case as 0 or 1+. You're not penalized for that distinction. It isn't flagged as discordant by CAP unless you call it positive. So in the end, I think, using proficiency survey data is interesting, but may be suboptimal as a way to examine this issue. Now, I'll have to say the researchers did go a step further, and they did look at more clinically relevant specimens. They looked at an archived series of 170 core needle biopsies, which were reread by 18 breast pathologists, and they saw similar results. Again, 3+ versus non-3+ agreement was high. The majority of the positive cases, there was near unanimous agreement, which is great. However, score 0 versus non-0 agreement for those core needle biopsies was significantly lower. And few cases really showed unanimous score 0 agreement, and actually only 26% of the negative cases showed greater than 90% agreement. And again, it seems as though the data would suggest that agreement at the low end of the spectrum is not great. However, the authors did acknowledge some study limitations that I think are relevant. One, that none of the 18 pathologists that were told that 0 versus 1+ concordance was going to be assessed. And many of them did acknowledge that had they been aware of that, the intent of that study, they would have examined some of those low HER2 expressing tumors maybe a little bit more carefully. So really the take-home point and the message I want to drive home here is that if not much attention or bandwidth by practicing pathologists is given to identifying low levels of HER2 expression, either on a proficiency survey or even in clinical practice, agreement and reproducibility may suffer. So how do we move forward? How can we improve and optimize detection of tumors with low levels of HER2 expression? And I think the answer to this question in the near term is we have to really optimize the tools that we have in hand. And I think that will require a couple things. One, optimization of our current FDA-approved methods for HER2 detection, controlling as best we can, pre-analytic and analytic variables, improving our operator competency, strict or as strict as possible adherence to the ASCO-CAP HER2 IHC interpretation guidelines, and looking forward, consideration, of potentially new assays or methodologies for detection or quantification. For example, utilizing digital pathology and artificial intelligence for assisted scoring. These things may be valuable. Because, as I said before, the diagnostic and therapeutic landscape for HER2 continues to evolve. We, as pathologists, need to be prepared for that. We must adapt. In the meantime, immediately, as a practical matter, I do think pathologists may need to spend, more time with their cases, more time with their HER2, be more careful in examining the staining patterns of their cases to better discern score 0 from 1+ expression. So let's transition here, and we'll talk a little bit more in detail about optimizing performance and consistency in reading HER2 across the spectrum of expression. Now, I think assuring optimal performance is dependent on multiple factors, and we have to think about all of these. One, from the type of specimen that is selected for testing, to pre-analytics, specimen handling, things like cold ischemic time, to other analytic factors, differences in the methodologies that we use, interlaboratory variations in performance, even operator-level competency and skill, participation in things like internal QC and QA. These are all things that could potentially impact our HER2 scoring performance. And so we'll go through all of these factors one by one. So the type of specimen which is used for HER2 assessment is an important variable. Now, by and large, for primary breast cancers, biomarkers are assessed on core needle biopsy specimens, and this offers some advantages. Generally, these are not prone to issues like prolonged cold ischemic time. They go straight into formalin. However, one major disadvantage is that inherently with the core needle biopsy, these are subject to sampling error. And this is an issue, especially if you're dealing with a large tumor with potential intratumoral heterogeneity for HER2 expression. What you see, what you get on the biopsy may not be representative of the entire tumor. So, as an aside, I think it also remains to be seen whether biopsy versus resection is best for detecting HER2 expression at the low end of the spectrum. Of note, also, core needle biopsies may be potentially more susceptible to crush artifact that limits interpretation. Pathologists should avoid scoring HER2 in areas that show crush. Edge artifact is also something that pathologists need to be aware of. The images here on the bottom row show an example of edge artifact. So that's a phenomenon in which your IHC expression at the edges of the tissue is accentuated and is sort of negative in the middle of the tissue. And when you see that, that's really a red flag that there may be something wrong with the fixation or processing. So at a minimum, pathologists should be aware and should avoid scoring in cases that demonstrate these types of artifacts. A second important variable to consider is tissue site, specifically as it pertains to potential exposure of that specimen to decalcification solutions. So this is very highly relevant in breast cancer, as bone metastases are a common site that are sampled, that are tested. Generally speaking, decalcification reduces the antigenicity of the molecules targeted by IHC and causes potential false negative results. Breast biomarkers, including HER2, are not validated in decalcified specimens, and the presence of decalcification should be noted in a comment at least or flagged as indeterminate as per ASCO-CAP guidelines. These images I'm showing you here are from an interesting study from the Netherlands that was published in Modern Pathology. This study was interesting because they used more, quote, gentle or molecular-friendly solutions like EDTA and some formic acid-based solutions, and they compared the impact of those treatments on ERPR and HER2 IHC on 23 different breast cancers. And the image I'm showing you here is from one of the 3+ positive cases on the left. That image is the control with no exposure to decal, and on the right, various different decal solutions. And what they observed was that reductions in the expression of HER2 IHC. In their series, they observed 9% of the cases in which there was a potential impact to therapeutic decision-making as a result of the effect of decal. And this is a 3+ case. So as you can imagine, the negative impact of decalcification may be even more pronounced in tumors with more subtle, low levels of HER2 expression. So that's something we need to be mindful of. A third important technical consideration involves the age of the specimens that we use to test biomarkers. Where possible, one should use freshly cut, unstained slides for HER2 assessment and try to avoid testing on archived, pre-cut, unstained slides, as these can show staining degradation, and this is due to cut sample instability. These are images I'm showing you from an older study from Switzerland, also published in Modern Pathology. They compared the staining intensity in a series of 522 breast cases using freshly cut unstained slides versus the archived slides that were 6 months old. And they observed that slide age had a negative impact on staining intensity. Their HER2 positive rate decreased from 16.3% overall to 9.6%. And as you can imagine, the potential impact on low levels of HER2 expression could be even more profound. So again, when performing HER2 IHC, this is just yet another thing to factor into consideration. Of course, understandably, in some situations, older archived specimens may be all that is practically available to you, but when possible, fresh cut slides from those stored blocks should be used. Of course, another important pre-analytic factor involves fixation and cold ischemic time. The ASCO-CAP guidelines stress the importance of proper fixation. Fixation time has to be within 6 to 72 hours. A bigger issue is cold ischemic time, and that is, of course, defined as the elapsed time between the moment that specimen is removed from the patient to the time it goes into formalin. Numerous published studies have shown that tissues that are subjected to prolonged cold ischemic time can yield false negative biomarker results. This is an example of an excellent study that came from the University of Pittsburgh. For modern pathology, they subjected breast tissues to varying increasing lengths of cold ischemic time, and then they compared the ERPR and HER2 results. In this example, HER2 on the left image has only 30 minutes of cold time, and it's positive. After 3 hours, the second image over, that signal has really started to degrade, and it's basically dead negative after a day. So, we have to think about our lab policies and protocols to minimize cold ischemic time always. Practically speaking, I think this pertains to resection specimens and perhaps even metastatic specimens, as these are the ones that are more likely to be subjected to cold ischemic times. And again, I do think this issue may be exacerbated when we consider tumors with subtle or the lower spectrum of HER2 expression. And lastly, we have to consider differences in the assay itself. Now, currently, there are several FDA-approved assays that are cleared for HER2 IHC assessment. Now, all of these, they're all called HER2, but they utilize different antibodies. They have different detection and retrieval systems. They have different performance characteristics, and so they're different. At our institution, we use 4B5, but I encounter different HER2 IHC on our consult service as I see, cases done where biomarkers are done at outside labs. And when you look at them, the stains just look different. They look different in intensity. They look different in staining quality and background. And so for these assays, while analytic validation and agreement has been very well studied in identifying HER2-positive disease, a lot less is known about their comparative performance in detecting tumors with lower levels of HER2 expression. And so that's something we need to all bear in mind going forward.
Thank you, Dr. Tozbikian. This has been a wonderful session so far. It's just absolutely marvelous. I'm going to run through now our very first poll for the audience, and that's posted now, and you can vote. What type of IHC assay do you routinely use for HER2 testing? You'll see the answers there. I'll give you one more second. You see the leading systems there and also other, with a fairly even distribution between the HER2 test and the pathway. Very good. We'll take that poll down, and Dr. Tozbikian, go ahead and proceed. Thank you.
Thank you. So that was very interesting. It looks like from the polling that the 4B5 Roche and the HER2 test, choices B and D were the most popular. But, the point is that, the assays that are used in labs are not uniform, across laboratories. And that variability is something we have to consider especially when thinking about clinical detection of tumors with low levels of HER2 expression. So in the next few slides, we're going to sort of transition here. We're going to briefly review the current ASCO-CAP guideline scoring interpretation, guidelines for HER2 IHC, starting with the HER2 positive result or a 3+ result. This is defined as tumors showing greater than 10% of the tumor cells with complete intense circumferential staining. And I'm showing some example images here utilizing different kits. And you can see they look different. Next, for equivocal or 2+ results, these are defined as tumors showing greater than 10% of the cells with weak to moderate complete membrane staining, or less common staining patterns that are also considered 2+ include incomplete basolateral staining that is seen in, say, micropapillary tumors, or intense complete staining that is seen in less than 10% of the tumor cells. That is also considered a 2+, and these would require reflex HER2-ish for arbitration. HER2 negative score 1+ is defined as tumors showing incomplete membrane staining that is faint, or barely perceptible and observed in greater than 10% of the tumor cells. And finally, a score 0 is defined as either a complete absence of staining or incomplete, faint, barely perceptible staining that is seen in less than or equal to 10% of the tumor cells. So, at the lower end of the spectrum of HER2 expression, the differences in staining between a score 0 and a 1+ can be subtle, and to be able to make that distinction requires very careful examination of the entire tumor. So I recommend initially scanning the tumor at low magnification to evaluate for that presence of intratumoral heterogeneity. Now, to be able to detect low levels of HER2 expression, it really requires that the pathologist carefully interrogate the tumor at higher power. I mean, there's simply no avoiding this. It can't be done at scanning magnification alone. So in 2+ cases, the staining precipitates are generally starting to get visible at medium power using the 10x objective lens. But to observe 1+ staining really requires the pathologist to go to high power, generally the 40x objective lens. And then it requires that pathologist to spend some time being at 400x magnification to try and quantitate and see whether or not that tumor really meets that 10% threshold or not. And I'm showing you an example image here. This is a case with 1+ expression. And you can see that at 40x, the staining quality, that staining it's incomplete. It's only partially circumscribing the cells. On the top left here, you can see it has a bit of a sort of a granular quality, sort of a dot-like quality, but it does follow a membranous pattern. It's basically very difficult to detect or quantitate that level of subtle expression at low or medium magnification using a 5x or 10x objective. So at the end of the day, detection of tumors with low levels of HER2 expression will require a pathologist to just spend more time with our cases. For difficult cases, I would also recommend other quality assurance measures, QAing the case with a second pathologist for consensus. Furthermore, I think there's always a role for improved training and more rigorous adherence to the current ASCO-CAP scoring criteria. I think all of these things have an important role in improving reproducibility and inter-observer agreement in cases that have low levels of HER2 expression. Lastly, a few points on reporting results. The CAP reporting templates require that HER2 IHC results be reported in a standardized fashion as listed here, with the available result options I've highlighted. They're highlighted here in red. So your options are negative score 0, 1+, equivocal 2+, or positive 3+. At this point, enumerating specifically a percentage of cells that are staining, it is indicated in the CAP checklist, but it's not required and it's not widely done. But what is not recommended, what I do not recommend, is only providing a final HER2 interpretation as positive or negative without providing that specific attendance score of 0 to 3+. It's very helpful to provide both. Also, reporting HER2 results in a synoptic style of report or an outline style is very helpful for improving clarity and readability for the treating physicians. And finally, it's recommended to document in the report the methods, primary antibody used, obviously, as well as formalin and cold ischemic. In terms of HER2 testing, this is a multidisciplinary effort. It's not just about us pathologists. I want to share with you, this is a diagram of the multidisciplinary treatment team. Obviously, the pathologist plays an absolutely key role in terms of interpreting the results, reporting the results, ensuring the accuracy, ensuring the quality, but it's not just about us. The clinical team plays a key role, for example, especially regarding pre-analytics, ensuring tissue integrity by minimizing cold ischemic time. Likewise, it's them. They are primarily the individuals who communicate those results to the patient, who is a member of the overall team. Utilizing synoptic styles of reporting for biomarkers is helpful for all the stakeholders to promote that clarity and that efficiency in decision-making. And also, if you can do it, having discrete or smart data results for your biomarkers, if your LIS allows for it, pays in dividends as these results are utilized by your researchers and your cancer registrars in building data sets which can help with your overall research and other care enterprise.
Thank you once again, and we'll pause now for our second poll. In discriminating between HER2 IHC 0 and 1+ to identify low levels of HER2 expression, what do you perceive could have the biggest impact? And so I'm going to let you noodle on these options for a bit before we finally settle in. Assay antibody choice, additional training and practice, more time. Okay, we're finally seeing some equilibrium there on those results, including additional training and practice, always a popular choice, I'm sure. Dr. Tozbikian, go ahead and resume. You might wish to comment on these and then continue.
So this is very interesting. As the audience seems to pick up on, every one of these answer choices is a right answer. It seems like overall, perhaps people feel that having additional training or resources and spending more time on their cases would be the most useful. But all of these things, in my opinion, are important. It's important that we have assays that are sensitive. And we have to look at that for low HER2 tumors. For borderline cases, difficult cases, getting that second opinion I think is useful. For consensus scoring, having good quality and adherence to our interpretation guidelines, and spending more time. All of these things will, I think, enhance our accuracy and quality. So we'll transition here. In the last few slides of the presentation, we'll go over some case examples and try and summarize some of the points here and demonstrate how this sort of looks in clinical practice. I've got a total of 3 cases to share. Each of one of them actually was, prior to this presentation, was independently scored by a panel of 9 expert breast pathologists. Scoring for these cases was done on scanned whole slide images, and a consensus score was determined. So you're only seeing a static, shot of these images. So I understand that's a little bit different than reviewing a whole slide image, but we can look at these. The first case is an example of a low-grade invasive lobular carcinoma. On the right, you can see the corresponding HER2 IHC at the 10 and 20x objective magnifications. And so how would you score the HER2? And I see some results coming in. We'll just let those, everyone have a chance to look at that. So it appears as though the results, the answers have sort of stabilized here. We've got about close to 80% at 1+ and about 20% at 2+. And so here, this is the consensus score from the expert panel, and the consensus score was a negative score of 1+. Now, like as I said, granted, looking at a static fixed PowerPoint image is not exactly the same thing as being able to evaluate the virtual slide, but in this case, just looking at the specific focused high-powered field, you can see that the staining pattern is membranous, but it's largely incomplete. Okay, it's not surrounding the entire circumference of the cell surface, okay, in 360 degrees. So that's important. There's only real partial circumscription of the cells that show expression. And moreover, that expression is weak. You really have to go to 20x or even higher power to really discern it. And when you do, at that power, the staining is very sort of dot-like. It's very granular. It's faint. But it's certainly present in greater than 10% of the tumor cells, at least in this field. And so, therefore, this qualifies as a 1+. Okay, moving to the next case. This is the second case. It is an example of a grade 3 invasive ductal carcinoma or non-special type. And we'll let people have an opportunity here to review the IHC. So it appears as though the majority of respondents have scored this as a 0, 85%, and then the second most popular result is about 11% with the 1+, and a few percent at 2+. So in this example, the consensus score was a 0 by the expert panel. So what you can see here at 20x on the right-hand image, there are some scattered cells with sort of barely perceptible membranous reactivity, okay, particularly sort of at 12 o'clock, 12 to 1 o'clock, 1 to 2 o'clock. But, and this staining is incomplete, right? It's only on a portion of the cell membrane, and it's very faint, very dot-like, sort of granular. And overall, if you had to look at this field, these appear to represent at least, less than 10% of the cells in this field, assuming, of course, that the rest of the tumor stains in a similar fashion. This would qualify as a score 0. One of those examples where it's not necessarily absent staining. It's not, it's not absent staining, but there is some low level of expression, but below that 10% threshold, and therefore is considered a score 0. Okay, the third and final case is an example of a grade 2 invasive ductal carcinoma or non-special type tumor. I'll let everybody have a chance to review this one. Okay, I think we have had the majority of the results here, and about 3/4 of the respondents have scored this as a 1+, about 20% a 2+, and a few have scored this as a 0. So this was an interesting case, certainly the most challenging of the three. And at medium power, at 10x, which you can appreciate some membranous reactivity. It's detectable. It's quite faint, but it's much more readily seen at 20x. The majority of that membranous staining is, however, quite faint. There are a few scattered cells at the 12 o'clock location that show slightly stronger staining, slightly stronger membranous reactivity, but still appears incomplete. The percentage of cells staining is close to that 10% threshold or cutoff in this field. And this was a case that actually engendered some differences of opinion amongst the panel. Now, the consensus score was 1+. However, there were a few pathologists amongst the group who did score this as a 0, and a handful that scored this as a 2+. So it just goes to show at the lower ranges of expression, even under controlled conditions, it can be a challenge to achieve perfect consensus. So this is the final slide. To conclude, HER2 assessment currently takes, a very binary approach to HER2 categorization. But we have learned today that a large number, approximately 60% of breast cancers, do express low levels of HER2 expression that are non-amplified. Now, these tumors with low levels of HER2 expression may represent an important potential group of clinical interest, particularly as the clinical treatment landscape continues to evolve. In order for us as pathologists to achieve reproducible and consistent results at this lower end of the spectrum of HER2 expression, it's going to require a few things. It's going to require increased training. It's going to require, increased operator competency. As much as possible, strict adherence to our ASCO-CAP scoring guidelines and criteria, more careful scoring, taking more time with our cases, and also optimizing our methods, using all our best practices, using synaptic reporting to report our HER2 results. It additionally improves our efficiency and clarity of those results because these are utilized by the broader multidisciplinary team. So with that, I would like to thank all of you for your attention. And at this point, I'd like to be able to take any questions. Thank you.
Dr. Tozbikian, thank you so much for a masterful presentation of a topic that's getting a lot of attention. And as you can imagine, we've got many questions and comments. I'd like to make a couple of general remarks before I start. We don't have a lot of time, so I want you to know if you've made a comment or have a question, those will all be dealt with both by ourselves here at CAP today and Dr. Tozbikian with his good graces. And let me plunge right in then. One more point, we did not design this to be a debate about specific assays, and so comments there, for the time being, I'm going to leave to one side, but instead focus in on multiple questions regarding what would be a best practice in light of what we're seeing in the low HER2 results as reported widely. So let me begin by asking you this. If clients at our laboratory order HER2 FISH by itself to our lab and it turns out to be negative, group 5 negative, do you recommend now reflexing these types of cases to HER2 IHC in order to detect HER2 low expression tumors? What do you say to that, Dr. Tozbikian?
So the question, if I could rephrase it, and has to do with certain labs' protocols for HER2 assessment. Now, the current ASCO-CAP guidelines indicate that IHC and ISH are equivalent assays, and either or can be the initial test. And the current guidelines, state that basically if your initial result is negative by IHC or FISH, assuming that that the result makes sense, there's no problems with discordance or controls, that you're done, and that continues to be the case. I think it begs a very specific question because in studies of tumors that have low HER2 expression, these are defined by IHC expression, right? So it remains to, it would be a challenge to be able to identify tumors with low levels of HER2 expression because this is defined by IHC expression. I think currently, the guidelines stand. There are no changes to the guideline recommendations. I would not, but I think we have to be open to the fact that as this information and data continues to mature, that we be open to this continued evolution in the treatment landscape, and we have to respond to that as pathologists. HER2 continues to evolve, and our practices and how we evaluate has to continue to evolve, and so we have to be open to that.
Thank you. Thank you very much. There's a couple of questions really I would like to get a clarification on. This regarding your early comments about the important prognostic implications of HER2 heterogeneous tumors. Could you compare the prognostic implication of the heterogeneous tumors to the prognosis for HER2 negative tumors? I hope I'm clear.
So there have been a number of various papers that have looked at the prognostic importance of intratumoral heterogeneity. And just sort of to summarize, some of the data is conflicting. For example, in those cases that are HER2 positive with intratumoral heterogeneity, there has been observations or correlations with poor survival and less response, less PCR response to neoadjuvant chemotherapy. But there has been sort of data on both sides. I think overall it is still unclear and not fully understood what the overall survival implication is of having intratumoral heterogeneity for HER2, and particularly at the low end of the spectrum.
Very good. Let me ask you what I hope will be a slightly easier question. For the heterogeneity issue of the tumor, if the HER2 IHC is 0 and or 1+, do you think another slide should be tested? Okay.
So if I had to rephrase, if you say on a primary tumor, if your initial HER2 IHC result is negative, 0 or 1+, but perhaps you are thinking about the potential for intratumoral heterogeneity, what would be the appropriate next step? Should there be repeat testing, right? So again, I'll back it, and that's an excellent question, and that's an open question for debate. And I think currently, if you look at the ASCO-CAP guidelines, they give some flexibility to the pathologist to decide on a case-by-case basis when it would be appropriate to do repeat testing. There's no strict answer to that. I think repeat testing is always, a good idea and should be indicated, and it really depends on a case-by-case basis. For example, if you have a situation where you have a large tumor, okay, and there may be even regions of the tumor on resection that show, morphologic differences, changes in grade, things like that. That would be a situation where, a pathologist may say, hey, what was on the core needle biopsy may not be representative of what may be on the resection. And that's true for all cases, not just low HER2 positive cases. And so in that situation, it might be reasonable to do repeat testing. In contrast to that, if you have a very small tumor and the sampling was good on biopsy, what you saw in the biopsy was probably representative of the tumor. This is a small lesion, PT1 size tumor. Probably you're not going to get, practically speaking, a different result. It was very well sampled initially. So it sort of just depends. There's no single right answer. And I think, it begs the question when you consider the fact that, based on the literature, upwards of 10-15% of tumors will show some levels of intratumoral heterogeneity for HER2. What should be the best approach and algorithm for picking up these cases? Is it best to do it on the biopsy alone? Is there a role for repeat testing on the resection? What is the agreement or concordance of this low levels of HER2 expression between the core needle biopsy and the resection? These are all open questions and should be looked at. There is no answer for that right now.
Thank you. Thank you very much. As you know, your presentation is going to stimulate lots of thought and lots of further research and experiment in many, many places. Now, given, Dr. Tozbikian, the fact that you're sort of at the house of digital pathology, that is to say at The Ohio State University, could you share with us briefly, and I'll make this the final topic today, your thoughts on the computerized aid, or in fact artificial intelligence aiding in HER2 IHC scoring?
Right. So what would be the potential role of digital tools for quantification for HER2? That's an excellent question. I think this is something just quantitative biomarker quantification and scoring is something that's looked at actively at our institution as well as other institutions. I think if I had to summarize what the multitude of papers have shown is that these technologies do enhance agreement and concordance. Of course, these are new technologies. These things have to be validated analytically and, more important, clinically before there's wide adoption. Pathology changes, the landscape changes, the technology changes. I think I would not be surprised, looking ahead, forecasting ahead, that there may be a role for these technologies in biomarker assessment in HER2 and beyond.
Thank you. Thank you very much, and I'll give you the last word with that very, very good answer, I think. And I'll begin to sum up now, as we're right at the top of the hour, essentially. So I really want to thank Dr. Gary Tozbikian of The Ohio State University. What a magnificent presentation. Let me remind you, in about a week or so, you'll be able to enjoy this again and review it at captodayon.com. I want to thank Daiichi Sankyo and AstraZeneca for their help in enabling us to put on this very important CAP Today webinar. And finally, I want to thank all of you. I know things are very busy, and there is plenty and plenty of work to do in situations where staff is not as plentiful as any of us might wish, in any place where we might wish. And so I want to thank you. It really means a lot for us when you attend and participate in these CAP Today webinars. And so once again, to sum it up, thanks to Dr. Gary Tozbikian, Thanks to Daiichi Sankyo and AstraZeneca, and thanks to all of you for attending today. And with that, I'll bring today's CAP Today webinar to a close.